Today's webinar will focus on the rationale and practical aspects of incorporating a cytokine absorption cartridge in a bypass circuit with Ecmo as a strategy to treat cytokine storm and hyperinflammation in the critically ill COVID-19 patients with respiratory failure. Today's webinar consists of the following speakers: Dr. Philip Chan, CEO, CytoSorb Corporation, and Mr. Stefan Zago, Ulm University, Ulm, Germany. Your moderators will be Linda Mangiero and Luke Pui. I am Linda Mangiero. I'm one of your moderators, and I am the Vice President of ECLS and Ecmo at Specialty Care in Nashville, Tennessee. My co-moderator for today's broadcast is Luke Pui. Luke?
Thank you, Linda. So today's broadcast will be recorded for future playback. We will have our two speakers, and afterwards we will have a 10 to 15 minutes Q&A. Please submit your questions using the Q&A function at the bottom of the Zoom presentation window. And please address your question to a specific panelist so they know the answer to the question. If we do not get to your question, please consider submitting your question to the COVID-19 discussion forum linked on the Joint Perfusion COVID-19 Taskforce website. And we are happy to announce that the ABCP has approved the Joint Perfusion COVID-19 Taskforce to offer up to 1.8 category continuing education units for attendees of the live broadcast. After the conclusion of the broadcast, attendees will be provided with a link to a survey to claim your credits for the participation in the meeting and to provide the task force with information on the current operating status of your program. Even if you do not plan to claim credits, we would appreciate your responses to the survey. The survey link will also be sent off to all attendees one day after the live broadcast. And certificates to all registered attendees will be sent within 4 weeks of the broadcast. We would like to thank CytoSorb Corporation for sponsoring today's webcast. So Linda, it's up to you again.
Thank you, Luke. We'll start today with Dr. Philip Chan from CytoSorb Corporation.
Thank you very much, Linda. And special thanks to AMSECT, Jim Rieger, Tammy Rosenthal, Linda Mangiero, and Luke Pui for the kind invitation to be here today and to give you more information about CytoSorb and the use of cytokine absorption in critically ill COVID-19 patients under FDA emergency authorization. I'm joined here today by two of my additional colleagues from CytoSorb, including Mr. Vince Capone, Chief Operating Officer and President, and Parker Hutchinson, who many of you may already know as being instrumental in the training on CytoSorb in Ecmo and on CRRT as well. And wanted to thank Rona Kalinga for her technical help in getting this set up, and Dr. Stefan Zago for joining us today, also from Germany. So just as a quick disclaimer, CytoSorb was granted FDA emergency use authorization in April 2020. The CytoSorb device has been authorized by FDA under an emergency use authorization to specifically treat patients 18 years of age or older with confirmed COVID-19 admitted to the ICU with confirmed or imminent respiratory failure. The CytoSorb device has neither been cleared nor approved for the indication to treat patients with COVID-19 infection. This is the case for all therapies being used to treat COVID-19 today, including remdesivir, which is also emergency use authorized. The CytoSorb device is authorized only for the duration of the declaration that circumstances exist, justifying the authorization of the emergency use of CytoSorb device under section 564B under the Act, unless the authorization is terminated or revoked sooner. So just a little bit of background on myself. I'm Dr. Philip Chan. I'm the CEO of CytoSorb and have been leading the company for the past dozen years from a preclinical stage to EU approval of CytoSorb and commercialization of this device in 65 countries around the world as a way to control deadly inflammation through blood purification. I am an MD, PhD internal medicine physician by background, with my MD, PhD from Yale School of Medicine and my internal medicine residency from the Beth Israel Deaconess Medical Center at Harvard. and received board certification from the American Board of Internal Medicine in 2004. As a disclaimer, as I mentioned, I'm an executive, board director, and shareholder of CytoSorbent. So today we're talking about the application of CytoSorb under FDA emergency use authorization in critically ill adult COVID-19 patients with confirmed or imminent respiratory failure. And the FDA allows actually a quite broad range of use of CytoSorb in these patients in three categories. One are patients with early or acute lung injury with early or acute respiratory distress syndrome. The second category actually provides for earlier usage, as defined as severe disease with people with dyspnea, respiratory frequency with a rate greater than 30 per minute, a blood oxygen saturation of less than 93% on room air, and either a PF ratio less than 300 or lung infiltrates greater than 50% within 24 to 48 hours by chest X-ray. And the third category would be classified as relatively late treatment in patients with respiratory failure or septic shock or other multiple organ dysfunction and failure. Now, the EUA is fundamentally different from the FDA's expanded access program for medical devices, which encompasses the more traditional emergency and compassionate use. In this particular program, therapies that are still investigational in the United States can be made available under emergency use for those patients who have exhausted all standard therapies. This typically requires ethics committee approval. It requires a third-party physician evaluation and that everything has been tried and has failed, and the patient will likely die if nothing else is done. And under this program, it really represents more of a therapy of last resort when they bring other therapies on board. Fortunately, that is not what emergency use authorization is about. And in fact, as I mentioned before, the FDA will actually allow early use, even on patients who are not yet mechanically ventilated, but are pending imminent mechanical ventilation. And this can be, CytoSorb can actually be used off the shelf like any other ICU product that you have, and does not need ethics committee approval. Now, CytoSorb has been used in more than 2,300 COVID-19 patients in 30 countries around the world, and as an extracorporeal cytokine adsorber approved in the European Union, has been delivered to date with more than 100,000 cartridges around the world. And in the COVID-19 pandemic, there's been actually a lot of activity around the world where blood purification to treat cytokine storm for COVID-19 is in the Chinese guidelines for treatment. CytoSorb is specifically in the expert consensus in Colombia. CytoSorb is the subject of a MedTech innovation briefing by NICE in Great Britain. It is the subject of multiple courses in COVID-19 in Germany. CytoSorb is specifically approved in India and in Israel for the treatment of COVID-19, and it is also recommended in the Italy and Panama guidelines as well. So when we talk about the pathology of severe COVID-19 infection, it's very clear that SARS-CoV-2 is a very dangerous virus. It causes a very severe viral pneumonitis and viral pneumonia that creates a local injury in the lungs and triggers the production of local cytokines and chemokines that ultimately go systemic and result in the ongoing production and stimulation of more cytokine production, leading to this upward spiral of cytokine storm, ultimately leading to a hyperinflammatory state and a dysregulated immune response that can lead to multiple organ failure. And what CytoSorb is designed to do is to try to quell that cytokine storm by physically removing cytokines from the circulation. Now, for example, in COVID-19, ARDS is a tale of two types of lung injury. On one hand, you get the very traditional exudative ARDS, and this is typically caused by hyperinflammation and cytokine storm that leads to endothelial tight junction disruption and leads to a hallmark of ARDS, which is capillary leak syndrome. This ultimately leads to pulmonary edema, very heavy, wet lungs that are very difficult to ventilate, leading ultimately to hypoxia and often hypercarbia. Now, in COVID-19, we are seeing a second type of ARDS, a more atypical ARDS, that is caused by thrombotic complications. And these thrombotic complications often are believed to have a root in direct endothelial injury caused by either viral infection cytokine storm, or activated complement. And that often leads to a coagulopathy and a coagulation cascade, leading to a depletion of anticoagulant factors. That then leads to a procoagulant state and a hypercoagulability that all of you on this call no doubt have seen firsthand. This often leads to macrovascular clotting issues such as DVTs and pulmonary emboli, but it also leads to microvascular thrombus, often called thrombotic microangiopathy, where you get tiny blood clots in the capillary beds in vital organs like the lungs, the kidneys, and many other organs. And that ultimately leads to a ventilation perfusion or VQ mismatch, where these patients are actually quite easy to ventilate. However, they are severely hypoxic and often severely hypercarbic as well, with high levels of D-dimers that are byproducts of this clot burden. And you can just see here in this little picture here, this is an autopsy specimen of a lung taken from a deceased COVID-19 patient, where you can see the macrovascular clot, these big clots here, but you can also see a lot of discoloration, which represents the more microvascular clotting that is happening in these lungs. And what we find, however, is that it's not just one or the other, but it's typically both. And in many patients, they exhibit both of these phenomena. And the goal of cytokine adsorption in these patients is pretty simple. Reduction of cytokine storm through cytokine adsorption and blood purification may help to limit this injury on both sides of this equation to help the lungs recover and heal. Now, to tell you a little bit more about what CytoSorb is and how it works, I present this slide. So CytoSorb is filled with hundreds of thousands of tiny porous polymer beads that are roughly the size of a grain of salt. Each of these beads has millions of pores and channels in them that allow them to act like sponges to be able to extract toxic materials from blood very efficiently through really three mechanisms. One, you have to be the right size to get into the pores, so pore capture. Two, the polymer is a hydrophobic polymer and can bind other hydrophobic substances. And proteins and peptides turn out to often have a part hydrophilic and part hydrophobic nature to them because of the variety of different amino acid side chains that make up these proteins. And then the third way that it removes things is based on concentration. It's just a simple law of physics. The higher the concentration of things pushing themselves into the pores of the bead, the more the beads remove. And you can see here just a schematic diagram of a cutaway of the beads, where big things like cells and antibodies, they're too big. They can't get in these pores that are typically have an upper cutoff of about 60 kilodaltons in size. Whereas very small things like electrolytes and go straight through the bead and are unaffected. But appropriately sized molecules, particularly cytokines and other inflammatory mediators, can go into this vast network of pores and channels, ultimately never to come out. And you can see how effectively it can remove things in the lower diagram here, where this is in vitro whole blood recirculation system that has been scaled for human treatment. And with CytoSorb, you can see a rapid reduction in IL-6, MIP-1 alpha, and gamma interferon, for example, with CytoSorb. And without CytoSorb, you can see that it's not removing much at all. And the important thing about this technology is that it does not require any type of affinity agent, no ligands, no antibodies, no biologics or cells. And the other thing about this technology is that it has massive surface area. So in a single one of these cartridges, you have 7 football fields or more than 45,000 square meters of surface area on which to bind cytokines. So just massive capacity. The good thing also about the technology is that it is plug and play compatible with the existing blood pumps that you have in the hospital today, whether or not it's a dialysis or CRRT machine or continuous renal replacement therapy machine, or if it's an Ecmo machine, or if it's a hemoperfusion machine. In fact, in Europe, it is also compatible with heart-lung machines as well. And one thing that Stefan will actually talk a little bit more about the setup, but a couple things that I just wanted to point out. One is that in Ecmo, which is really the focus of today's discussion, you note that CytoSorb is not in the mainline flow of of Ecmo. It is actually in a side circuit where it is coming off high pressure after the pump, going through the device. The device is positioned vertically to where blood goes in through the bottom, percolates through the top, and comes out the top, allowing for the best use and best contact of the resin beads with inside the cartridge. And then it goes back pre-pump. And actually, Stefan will go over a number of different configurations that you can use and several that you cannot. But that being said, the rationale of using CytoSorb again in these patients, particularly as it relates to capillary leak syndrome, can be illustrated by this experiment that was done previously. Now, this was a 32-year-old female with very severe influenza pneumonia, severely hypoxic with ARDS on ECMO, septic shock, acute kidney injury with a SOFA score of 18. They basically took a small amount of serum from her prior to CytoSorb treatment and then overlaid it onto human umbilical venous endothelial cells. This is a cell culture model of capillary leak syndrome. And when they did that, what they saw through immunohistochemistry and electrical impedance measurements is that it caused massive disruption of tight junctions, which are the spot welds, if you will, between endothelial cells that maintain the integrity of blood vessels. And then they treated the patient for 24 hours with CytoSorb, and then they did the same exact experiment, taking a small amount of serum and overlaying it onto new human umbilical venous endothelial cells. And what they found was that it did not cause this massive tight junction disruption. So what this suggests is that CytoSorb is removing actively things that are circulating in your bloodstream. And again, your lungs see the entire cardiac output, 4 to 5 liters of blood every single minute. And so it is removing something, whether or not it's hyperinflammatory cytokines or other factors that may be contributing to this capillary leak syndrome. And that by in doing so, CytoSorb may help to promote healing by preventing ongoing injury of the lungs. So let's talk about the ideal situation to initiate CytoSorb therapy. First of all, patients should meet the EUA criteria that we already discussed. Secondly, there should be no contraindications for use. Third, the patient should have evidence of hyperinflammation as judged by a high ferritin, often greater than 1,000, C-reactive protein that is also elevated, often greater than 100, and an IL-6, often greater than 500 picograms per mil. Now, many centers don't have access to IL-6, so as a rapid turnaround, so they send it out, but then they follow acutely the ferritin and C-reactive protein, which are typically very available to these patients, in these patients and in these hospitals. Fourth, that the patient who is hyperinflamed should also demonstrate either a rapid decline in respiratory failure, with respiratory failure imminent. And this is when CytoSorb is used, in fact, before mechanical ventilation. And in a couple centers in the United States and in several centers in Germany, they have used CytoSorb successfully to actually turn patients around and actually not need mechanical ventilation, but that is more anecdotal. But by far the more common usage is when patients first go on mechanical ventilation and are started on CytoSorb in a CRRT circuit, or when they start ECMO. And again, what preliminary unpublished reports have suggested is that early intervention achieves the greatest clinical benefit compared to delayed intervention. Vasopressor-dependent shock is not required, but often is where CytoSorb has helped, and I'll show you some data on that in a little bit. And again, if you're starting CytoSorb therapy, you would want to start it early, either concurrent with mechanical ventilation or concurrent with ECMO. Clearly, these are guidelines on the ideal situation and are not exclusive to other scenarios. However, we would not recommend this to be used on patients, for example, who have been on mechanical ventilation for 4 weeks, on ECMO for 2 weeks, who have no evidence of hyperinflammation, for example. That would not be a patient that you would want to try this on. Now, how to treat. We recommend the use of 4 cartridges in 72 hours, where you change out the cartridge every 12 hours for the first 24 hours, and then change it every 24 hours on day 2 and day 3. In Ecmo, we are recommending blood flow ranges of 300 to 600 mils per minute with a range of 100 to 700 mils per minute. This is a very high flow, low resistance technology that does not cause hemolysis up to 700 mils a minute. And so that's one of the great things about the technology. In CRRT, we are recommending 200 to 250 mils a minute of blood flow. Again, a range of 100 to, in most cases, they never max out to more than 300 mils a minute. We recommend that you try to avoid very low flow rates down in the 100 mils per minute range, because then in hypercoagulable patients, they have more of a tendency to have sludging of blood, and their clotting would be more frequent. Now, signs of potential benefit. What we see routinely is a reduction in inflammatory markers like IL-6, PCT, CRP, and ferritin. What I would also say, and is highlighted here on the right-hand side, is we would not recommend using D-dimers as a marker of hyperinflammation. D-dimers are, in fact, a marker of extensive clot formation, and no amount of cytokine reduction will dissolve a clot. And so if someone has very high levels of D-dimers, that may often be treating too late. What you're really looking for is someone with relatively low levels of D-dimers that are rising rapidly, and then intervening with extracorporeal blood purification with CytoSorb and heparin anticoagulation may help to prevent that ongoing clot formation. Second thing that we often see is a rapid improvement in hemodynamic stabilization, a decreased need for vasopressors with a rise in the mean arterial blood pressure, a stabilization of fluid balance, and a decrease or stabilization of lactate levels. Now, we also often see an improvement in lung function, but to be clear, this often is delayed. So while they're on therapy, you should see an improvement in PF ratio, a reduced FiO2 in patients on mechanical ventilation. Often they're seeing an improvement in lung compliance, an improvement in parameters of mechanical ventilation, and improved ABGs. And on ECMO, you're seeing reduced need for oxygen, reduced hypercarbia, reduced sweep gas flows, and improved ABGs. But recall that the underlying mechanism of CytoSorb in ARDS patients is to remove the toxic insults to the lung that are causing ongoing damage. And then the lungs need a chance to heal, ultimately then leading to decannulation from ECMO, and then ultimately extubation from mechanical ventilation. And then also we've also seen improved renal function as well. Now, considerations when using other COVID-19 therapies. As I mentioned, CytoSorb removes things up to 60 kilodaltons in molecular weight. And so CytoSorb is in fact compatible with convalescent plasma and antibody therapies, as well as immunomodulators like tocilizumab, also called Actemra, that are typically greater than 150 kilodaltons in molecular weight. And these are far too large to be removed by CytoSorb, which has, again, an upper cutoff of about 60 kilodaltons in size. Special consideration when using remdesivir and dexamethasone. These are the two drugs that probably all of your centers are using now. But CytoSorb has the potential to remove these drugs. And but we have recommendations on how to treat. So these are typically given as once-a-day dosing drugs. And what we recommend is that, first of all, they're dosed before you start CytoSorb, and they're given 1 to 2 hours to allow tissue and cellular distribution so that we are not removing it, because we only are removing things in the blood circulation compartment, not the tissue and cellular compartment. And then every time on the 24-hour mark, when you're changing over CytoSorb therapy, that you stop CytoSorb therapy, you administer remdesivir and dexamethasone, you wait 1 to 2 hours, and then you start CytoSorb therapy again, a new cartridge again. Okay. Now, CytoSorb can also remove some antibiotics. It removes some, and it does not remove others. However, we have recommendations on adjusting the dosages of these antibiotics, often by either increasing the dose or by using therapeutic drug monitoring for things like vancomycin and aminoglycosides, or by giving an additional dose 1 hour after you start a new treatment, or, as we said with dexamethasone and remdesivir, dosing in between cartridges. And so our support staff are available to make recommendations to your pharmacy to help manage these antibiotic issues. And then the last thing is that CytoSorb is compatible with all catecholamine vasopressors, including norepinephrine, epinephrine, phenylephrine, dobutamine, dopamine, etc. However, vasopressin and angiotensin II are peptide analogs and may be removed. We don't have data that we can remove it, but theoretically we can. So if a patient is in shock on vasopressin or angiotensin monotherapy, they should be switched over to catecholamines so that to prevent sudden destabilization of the patient caused by inadvertent removal of vasopressin or angiotensin II by CytoSorb. To date, we've not really seen this happen, but in Europe, where we have extensive experience, they don't really use vasopressin as much as they do here in the United States. Okay, so turning to now CytoSorb and Ecmo to treat COVID-19 patients. The whole idea here is that CytoSorb, in combination with Ecmo, represents a novel and potentially effective lung resting or lung preservation strategy to treat COVID-19 ARDS by providing gas exchange on one hand with Ecmo and turning down the mechanical ventilator so that you aren't causing ventilator-induced lung injury, while you're also removing inflammatory toxins like cytokines that are circulating, thereby allowing the lungs to heal. And for many of you who don't know this, Dr. Robert Bartlett, the pioneer of Ecmo and was the former chief medical officer of cytosorbents for 10 years. And I've had the good fortune to have been in good dialogue with Dr. Bartlett throughout this COVID-19 pandemic and have exchanged a lot of ideas and concepts. And some of the advice that he has that may be helpful to all of you for the management of COVID-19 patients on Ecmo include the following. If possible, let Ecmo do the work of gas exchange. He's a firm believer that you do not need to supplement with mechanical ventilation to manage these patients, and that you should allow true lung rest and avoid ventilator-induced lung injury. But he knows, and we know, that many patients are often have very severe hypoxia and hypercarbia, where many centers are resorting to using mechanical ventilation and supplementing often with very high levels of oxygen. And that is kind of like filling a bathtub with the drain open, right? On one hand, you're trying to help the lungs and rest the lungs with Ecmo, but on the other hand, you're hurting the lungs by thrashing the lungs with high toxic levels of oxygen and baro and volume trauma. So one of the things that he notes, and we've seen as well, is that over the past several years, most hospitals have adopted blood preservation strategies where they've tolerated far lower hematocrits and hemoglobin levels than they have in the past. In the past, it typically was greater than 30. Now we're often with a hematocrit of 20 to 25, or a hemoglobin of 7 to 9, roughly. And what he would point out is that clearly blood is your gas exchange carrier in your body, and that in COVID-19 patients, they've witnessed that many of these patients are severely anemic. And you may have also heard that for whatever reason, people with type A blood, for example, typically have much more severe COVID-19 infection than those with type O blood, for example. So there's something here. And what he recommends is that rather than resorting to mechanical ventilation, first try to transfuse them up to a hemoglobin of 11 and 12. And at Rush Medical, for example, in Chicago, they've been doing this very successfully and having good outcomes. So, the goal, just to sum it up, the goal of cytokine absorption with CytoSorb and Ecmo in COVID-19 patients is to try to improve clinical outcomes. But it's not just to get patients off of Ecmo and off of mechanical ventilation, right? But it's to get them off of these things faster, right? By promoting a healing environment for the lungs. Now, to share with you just some data, first we'll go to Germany and the University of Freiburg and Dr. Alexander Zipati, who is running the CyCov trial, or the cytokine absorption in patients with severe COVID-19 pneumonia trial on Ecmo. And this is a 30-patient study, and they recently published kind of an outline of the study and some initial data on cytokine reduction, particularly IL-6 reduction in these patients, which is the primary endpoint of the study. And in this study, they're integrating CytoSorb with Ecmo shortly after Ecmo initiation. CytoSorb is changed every 24 hours for a total of 72 hours of treatment. And what they have shown is that, in this randomized controlled trial, in 4 treated, 4 control patients, that there's a more dramatic reduction in cytokine in IL-6 in these patients with CytoSorb here in blue, and as compared to the control group. Now turning to the Medical Center of Aurora and Dr. Michael Furstenberg, who's Chief of Cardiothoracic and Cardiovascular Surgery there. He, at a recent ELSO webinar, actually presented data on one of his Ecmo COVID-19 patients. Now, this was a very sick patient, young, 44 years old male, but 172 kilos, with all the risk factors that predict bad outcome, including hypertension, prediabetes, asthma, and chronic kidney disease. He had a history of 1 week of weakness, malaise, nausea, vomiting, diarrhea with a temperature of 102, and satting 91% on 2 liters of nasal cannula. And this patient was admitted very similar to patients you've seen in your hospitals. Initial CRP 9.2, got convalescent plasma, got a 5-day course of remdesivir, but continued to get progressively worse with a rising ferritin of 800, put on BiPAP, and ultimately transferred to the ICU, where he was ultimately intubated with high inspiratory pressures and high need for oxygen. ABG showed acidosis with high, low PO2, high PCO2, and high IL-6, not as high as we would typically see in true cytokine storm, which is often greater than 1,000 picograms per mil, but a high ferritin and a moderately high CRP as well. This was his admission chest X-ray when he came to the hospital, but this was his chest X-ray when they ultimately started him on VV ECMO, again, 5 days after he was intubated and they began mechanical ventilation. And on that same day, they started CytoSorb. I believe they did also, as we recommend, 72 hours of treatment with Q12 changes on the first day, followed by Q24 changes on the next 2 days. They supplemented with methylprednisolone, and that led to a significant reduction in inflammatory mediators and ultimately decannulation 9 days after the last CytoSorb treatment. And on the day of decannulation, the chest X-ray shows bilateral clearing. That patient ultimately self-extubated on June 22nd and was discharged to acute rehab, on July 11th. And in fact, on follow-up, was discharged home off oxygen, off dialysis, alive and well, which was a great case. And so turning now to Froder and the Medical College of Wisconsin and Dr. Lucian Durham, who is the Director of Mechanical Circulatory Support and ECMO there. He has summarized some patients here for me and was kind enough to share a little bit of his data and some insight into his patients. They've treated a total of 30 COVID-19 patients with ECMO at their institution, including 10 of whom they treated with ECMO and CytoSorb. And in these patients, they integrated ECMO shortly. They integrated CytoSorb into ECMO shortly after ECMO initiation, and they also used CytoSorb Q12 for the first day, then every 24 hours for a total of 72 hours of treatment. In some cases, they treated longer, and you can treat longer. In fact, if the patient has no contraindication and is doing better, there is the potential to treat an additional 3 days, changing the device out every 24 hours. And the most that we've heard for COVID-19 patients has been 8 days on CytoSorb therapy. But one of the interesting things that he points out is that CytoSorb seems to do better on those with very high ferritin levels. And he notes this is the trend in ferritin in those with lower levels of CytoSorb ferritin with CytoSorb, but then in those with high levels of ferritin. So you're talking about greater than 1,000, up here in this case, a mean of, I think, 8,000, and showing just a rapid reduction in ferritin with CytoSorb treatment. And in this case, they predominantly use CytoSorb alone as, and then he also noted a reduction in plasma-free hemoglobin and also a rapid reduction in CRP as well. And in summarizing his patients, he said that roughly a third of the patients at his institution on Ecmo received CytoSorb therapy. They generally selected more severely ill patients who exhibited high inflammation as indicated by high levels of ferritin to get CytoSorb. And that treatment resulted in a decrease in ferritin, CRP, and plasma-free hemoglobin, noting that those with high ferritin levels treated with CytoSorb had a more profound response. He did say that one patient saw a rebound in inflammatory markers, but just underwent a second round of CytoSorb treatment and responded positively with a rapid reduction in inflammatory mediators the second time around. That patient ultimately did well. And so he reports 80% survival in those patients treated with Ecmo and CytoSorb, with one patient still on, who recently started 2 weeks ago. This was an unusual patient who they didn't start early. That patient was I believe a transfer who was actually on Ecmo for 3 to 4 weeks, but was exhibiting hyperinflammation. That person is still on support, but doing well. You know, this 80% survival compares favorably to the ELSO dashboard that you can see on the front page, where I think they're reporting about 62% survival, which has improved over time. Dr. Durham would also note that in general, patients at their institution are doing pretty well on Ecmo. Again, CytoSorb is being reserved for those who have really high levels of inflammation. And he would note that while results appear promising, this cohort was limited by small numbers, and you know, so we should just take those data appropriately. Okay, so now turning to NYU and Dr. Nader Moazzami, who's chief of the Division of Heart and Lung Transplantation there. Dr. Moazzami it was actually one of the first people to put patients on CytoSorb on Ecmo in the United States. He actually treated 5 patients pre-emergency use authorization. So this is, again, the old, under the expanded access for medical devices pathway, therapy of last resort, Hail Mary, if you will, kind of therapy treatment. But has done a total of 10 patients. And one of the things I wanted to just show you is the first 4 patients that he treated here. Again, using CytoSorb plus Ecmo as a lung resting strategy to try to reverse ARDS. He used CytoSorb every 12 hours for the first 24 hours, then every 24 hours after that, for a total of 4 cartridges in 72 hours. For the sake of homogeneity, he did not treat longer than 72 hours, though has mentioned that you know, how he wonders how patients would have done with longer treatment. The blood flow rates at his institution were 400 to 500 mils a minute on Ecmo, with a range of 350 to 600 mils per minute. In these four patients, you can see a nice reduction in ferritin, a nice reduction in CRP in 3 of the 4 patients. No real change in D-dimers. And again, you don't necessarily expect this to happen because, first of all, D-dimers are very large typically. And again, they are not hyperinflammatory markers. They are a measure of clot burden in those patients. And then albumin is 67 kilodaltons of molecular weight, and CytoSorb was designed not to remove too much albumin, but we do remove some. But what you can see here is that even after 72 hours of intensive treatment, albumin really didn't change in these patients, which is a good thing. Now, they also saw a concentration-dependent reduction in IL-6, IL-2 receptor, and IL-10. In this case, IL-8 was normal in all patients. But this is really kind of a very interesting slide. This is the first 4 pre-EUA patients, numbers 1 through 4. The first one was started on mechanical ventilation, started on VV ECMO on day 4, started on CytoSorb On day 6, these triangles represent changes of the device, and then the stop sign is when CytoSorb was stopped. And at the time of this evaluation, which was actually several months ago, that patient was still on ECMO. However, the next patient, they started ECMO earlier. They started CytoSorb kind of late on day 8, again, pre-EUA. And interestingly, 5 days later, that patient was decannulated off of ECMO. And the next patient, this patient rapidly spiraled down, requiring VV ECMO on the first day. But then they started CytoSorb relatively late, but 5 days later, they were decannulated off of ECMO. And on the next patient, they started VV ECMO on the same day of mechanical ventilation, but they started CytoSorb earlier. And 5 days later, that patient was decannulated off of ECMO. And again, what you're not seeing is that they get decannulated off of ECMO while you're on CytoSorb treatment. But what is fascinating is, or what we're seeing here, the fact that we're promoting healing, and then it takes the lungs some time to heal, ultimately leading to improved oxygenation parameters and an ability to get them off of ECMO. And so when Dr. Moazami actually presented these data at the recent ELSO conference last month, and on all 10 patients, 5 pre-EUA, 5 treated post-EUA, the median age of, and then compared them a little bit to patients on ECMO alone. So like Dr. Durham at Froedtert, at NYU, they also did 30 patients on ECMO, 10 of whom were on CytoSorb as well. These patients were relatively young in age, mostly male, and a BMI on a little bit on the high side. That those treated with CytoSorb generally had more comorbidities than those in the ECMO alone group, and that you can see here the parameters of pH, PCO2, PF ratio, and vasopressor score. And he would note also that 70% of the patients in the ECMO group were on CytoSorb. 70% had septic shock on vasopressors in those patients getting CytoSorb and ECMO, versus only 45% out of the 20 patients on ECMO alone, reflecting, in his words, a sicker cohort. And so what he found was a statistically significant reduction in lactate, and also in inflammatory mediators such as lactate, LDH, ferritin, and procalcitonin, but also a significant a marked reduction rather in IL-2 receptor, IL-6, and IL-10, as well as reductions in C-reactive protein. These patients were pretty sick. The length of stay was not statistically different, but 53 days versus 38. But that 100% of the patients survived in the CytoSorb treatment group, compared to 90% in the control group. Now, these are not large groups of patients, so again, we have a limited ability to interpret these data. But what is interesting is that 80% of these patients were discharged from the hospital in the CytoSorb group. 20% or 2 are still admitted to the hospital on support. And he would also note that the overall experience at NYU has been pretty good. And again, they have been instituting ECMO on the earlier side in NYU. So his data suggests that 80% are discharged from the hospital that have gotten CytoSorb, including those where CytoSorb was used as a therapy of last resort. They had 100% survival with 2 patients still in the hospital, but again, due to small numbers, difficult to attribute to CytoSorb at this stage. However, they did see a significant decrease in inflammatory mediators like LDH, CRP, and ferritin, a significant decline in vasopressors, but not necessarily specific to CytoSorb, but a common theme. And in patients treated after EUA, where they did an extensive panel of 35 cytokines, they demonstrated a significant decline in a variety of cytokines and chemokines. And like all of the others that have been reported at other institutions in this webinar, they did not see any device-related adverse events. The only thing they saw in NYU was that 1 patient required substantial increase in sedation, And for this reason, the device was discontinued. But otherwise, no other major complications. Okay. And now just turning to but this whole concept of early intervention with ECMO, early intervention of CytoSorb is something that might be a strategy to help ARDS patients. And in a study in pneumogenic sepsis patients with ARDS on ECMO, who also are on vasopressors in shock, in a study that was published earlier this year, they reported on a prospective single-center study in 13 patients with pneumogenic sepsis, 3 influenza, 1 fungal, 9 bacterial, ARDS on VV ECMO compared to a historical control population of pneumogenic sepsis on ECMO. And what they did in these patients was that they actually got them on ECMO within 6 hours of admission to the ICU or within 12 hours of sepsis diagnosis. But these patients had crashed, meaning that they had full-blown respiratory failure on mechanical ventilation and needed ECMO right away. The SAPS-2 score, which is a measure of a level of acuity, shows that the CytoSorb group had a mean of 58, which predicts a mortality greater than 60%. And those in the control had a SAPS-2 score of 50, which predicts a mortality of greater than 50%. And all patients received at least 2 CytoSorb cartridges and a maximum of 3 with ECMO that were changed every 24 hours. Blood flow rates were 200 to 400 mils a minute. They saw a very dramatic reduction in CRP, PCT, as well as the need for norepinephrine compared to a much more variable course in the control. And importantly, they saw a rapid hemodynamic stabilization of these patients on norepinephrine. And they saw a mean duration on ECMO of 8 days, a range of 2 to 23 days, versus 19 days, a range of 13 to 30 days, which is more typical of patients that we're seeing in COVID-19 and in patients that you've no doubt seen as well with ARDS, often very sick. And interestingly, none of the patients died. Again, this is a prospectively enrolled study of rapid treatment with ECMO and CytoSorb, and none of those patients died. So this is not cherry-picked data of patients who survived. This is the prospective data on survival, but not a very large population. But that being said, all 13 survived and were all alive and out of the hospital doing well at 60 days versus 57% of patients dying in the control arm, which is more typical of what we would expect in this population. And so moving on, just some final words here on some things to look out for. Yes.
Sorry, I don't mean to be disrespectful, but we were a little bit on a time restraint, so we have another speaker. If you could wrap up or go a little faster, thank you.
Certainly. Yeah, I think that we should have plenty of time for questions and answers, but I absolutely will expedite this. So just as a plug, we have a CTC registry that is filed with clinicaltrials.gov that is up and running. In fact, University of Chicago Pritzker was one of the first centers to put data into this CTC registry that is collecting data from all over the United States in patients where CytoSorb is being used in hemoperfusion mode, CRRT mode, or ECMO. And the primary endpoint here is mortality. The secondary endpoints is duration on ECMO and mechanical ventilation and other factors. And if you are interested in participating in this, please reach out to Dr. Peter Nelson at Cytosorbents at pnelson@cytosorbents.com. Our goal is to get to 50 to 75 patients and publish data on what we have found. Now, some practical guidance on anticoagulation. We know that these patients are hypercoagulable, and CytoSorb is only compatible with heparin anticoagulation. We may remove, for example, bivalirudin and argatroban, and we definitely can remove antithrombotics like P2Y12 platelet inhibitors and factor 10A inhibitors like Xarelto, for example. And so you should only be using heparin on these patients and making sure that they're fully anticoagulated before you start CytoSorb therapy. The good part is that you don't need to change your anticoagulation protocol. So whatever you're using on ECMO, whether you're using PTT, ACT, or anti-factor 10A assays, anti-10A assays, you would anticoagulate them the same way. And the one thing I would say is that what they've done in Italy and what many centers are using in the United States is that if you're still having problems with hypercoagulability, that the addition of aspirin as an antiplatelet, which is compatible with CytoSorb, has been used successfully to try to manage this hypercoagulability. Okay. And contraindications for CytoSorb therapy, patients with very low platelet counts, as CytoSorb can bind activated platelets. Any pre-existing contraindication to extracorporeal therapy, known allergies to the extracorporeal circuit, a history of heparin-induced thrombocytopenia, which would then preclude the use of heparin. And so again, you can only use heparin in these patients. Acute sickle cell crisis, morbid obesity with a BMI greater than 40, any pre-existing advanced medical disease with life expectancy less than 1 month. This does not include COVID-19, but it includes things like cancer, for example. Treatment deemed clinically futile, pregnancy. And then relative contraindications are steroids in patients who are immune suppressed, but you can use, as I mentioned before, this with dexamethasone, but dosed appropriately. And then the potential risks are very similar to what you see in most extracorporeal therapies, particularly the risk of blood loss, air embolism, infection, and thrombosis. And so finally, my last slide is the economics of CytoSorb usage. So under the CARES Act and the medical severity DRG, patients requiring Ecmo are being reimbursed at $142,000. However, what we have found is that patients are in the hospital so long on Ecmo or mechanical ventilation that most hospitals are not being able to capture any of this. They're actually losing money on many of these Ecmo patients. And the cost economics argument for CytoSorb is that if CytoSorb can help decrease the time on mechanical ventilation and Ecmo at a full treatment cost of $6,000 for 4 cartridges, and with the average cost of a day in the ICU of $5,000, if you can just shave off 1 day off the ICU, CytoSorb would actually pay for itself. So with that, let me thank you very much for your attention here today. And now if we could save questions to the end, and I'll turn it over to Stefan to talk about how to set up the therapy in Ecmo. Stefan.
Thank you very much. Can you see my slides, or it's still not? Wait a minute.
Not yet. There you go. Yes.
Okay. So thank you very much for the introduction. Phil told already a lot of things. I might repeat, but I just overflew the slides. They are repeating some things. So my name is Stefan Seiger. I'm since 1996 perfusionist and European board certified perfusionist, 49 years old, and I am now a deputy senior perfusionist in our hospital. Living in Germany with my wife, 2 children, 14 and 10 years old, which are dreaming to become musicians, otherwise like me. Whatever, we enriched our therapy spectrum with the CytoSorb. Since 2013, and we also made several studies and publications about it. Now I am very pleased and honored to have this opportunity to share with you our experiences in Ecmo combined with CytoSorb. I was asking if there is any chance to provide general but also reliable technical support for an extreme illness situation, and how does the body react to this combination? It is widely known that extracorporeal membrane oxygenation is increasingly used in different forms of shock, lung failure, resuscitation, after heart surgery. The two forms of Ecmo application are well known, VV and VA approach, with their different indications, applications, and underlying pathophysiology. That provides cardiocirculatory assistance, blood decarboxylation and oxygenation in patients with cardiac or combined cardiorespiratory failure. While the implementation of dedicated Ecmo systems has brought huge benefits to patients over the last years, a considerable number of patients develop a systemic hyperinflammatory response as a complication, with various mechanisms appearing to be responsible for activation of the inflammatory system. This response is triggered by the underlying disease, which can be infectious or non-infectious in nature. Ecmo support itself, including shear forces, hypothermia, and contact activation by the artificial surfaces. Clinically, that may result in vasoplegia, acute kidney injury, intestinal ischemia, cognitive dysfunction, and multiple organ failure. Cytokines are regarded as important mediators in the systemic inflammatory response to extracorporeal circuits. The pro-inflammatory cytokines, one of them, which is very important, is IL-1, and there are the reference values, the tumor necrosis factor, IL-6, and IL-8 that could generate that so-called cytokine storm we have already heard about. A compensatory release of anti-inflammatory cytokines may be observed at the same time, and the rebalancing, this dysregulation of the inflammatory homeostasis with increased levels of pro and anti-inflammatory mediators is discussed to be important to recover and maintain a functional immune system. The CytoSorb has received increasing attention in the recent years as an additional treatment option for patients with elevated cytokine levels, which could lead to life-threatening complications. Its broad spectrum removal of inflammatory mediators is a beneficial property to support the re-establishing of a proper immune balance. I'm sure there will be many other added as the time passes and researchers progress. There are at the moment just a few case reports and small case series that talk about the beneficial use of the device in ECMO patients, but the evidence is certainly growing. Now to our VIP, the coronavirus. What's happening actually in the infection with this virus? Do you recognize this pathway? Dr. Chan had a very understandable presentation of this chain reaction. The pattern is quite the same. The virus can cause a respiratory disease, which can get worse, developing a pneumonia or an acute respiratory distress syndrome. If that is not possible to be controlled, the landslide is on its way down with his cytokine storm, and the immune system response is dysregulated. Anyway, it is a challenge for all of us, but there might be a little bit of hope. Just a few words about the criteria for considering CytoSorb in COVID-19 treatment. Besides the already known Ecmo ECLS support indication and ARDS are the need of CRRT because of acute kidney injury, the refractory vasoplegic shock, and the typical H score. suggesting a secondary hemophagocytic lymphohistiocytosis. A cytokine profile resembling secondary HLH is associated with COVID-19 disease severity, characterized by increased levels of different inflammatory markers. Now, a few words to the setup. The most recommended insertion modality of an adsorber into the Ecmo circuit is the passive way, without an extra pump needed. That happens when the CytoSorb is integrated on a shunt line on the main extracorporeal circuit using the spontaneous blood flow from the high pressure port located after the pump to the low pressure port located before the pump. This setup is actually easy done if the pump is separated from the oxygenator. It depends on what kind of system you have. But what if the pump is integrated into the oxygenator, like ours, the HLS system on CardioHelp? There's a possibility to combine Ecmo with a CRRT, if that's indicated. That can be used independently from Ecmo ACLS system. The adsorber can be installed pre-dialyzer, like we also mostly do, or post-dialyzer. There you can see another list of options to combine CytoSorb with an Ecmo, such as passive solution, active solution, or independent solution. But you see in the right corner a picture which is a very, very important issue. Never bypass the oxygenator. I hope you can realize why. The safe anticoagulation management is, as we have heard already, heparin. Other substances could be removed by the adsorber. The typical Ecmo anticoagulation is sufficient to run the CytoSorb. Our ACT target is about between 180 and 220 seconds. And because of hypercoagulability in COVID-19, we keep it around 200 seconds. You can also consider the use of aspirin to improve and stabilize the anticoagulation. We have an easy manageable setup that you can see on a table, +4 clamps and 2-liter saline solution to purge the cartridge. This is very much like the description in the picture. There is mainly recommended procedure to integrate the adsorber into the Ecmo circuit. So after setting up and priming the Ecmo according to the manufacturer's instructions, connect and deaerate the connectors or two-way stopcocks or whatever is allowed and possible to your own setup. Connect the Ecmo to the patient and run the therapy. Flush now the cartridge by slightly tapping it to completely deaerate it. The lines used for purging, that's very important, must be filled previously to not get air into the device. That prevents building of clots and provide a proper function using the whole adsorption surface. Now connect the CytoSorb post pump to the high pressure port. That's very important. You'll see why. And fill the CytoSorb with blood, flushing the saline solution into the bag. Now you can connect bubble-free to the pre-pump port and think about clamping the lines before each connection. Now you can run the therapy with CytoSorb by opening all the clamps. Anticoagulation, as I said, is according to the standard Ecmo protocol. There's an animation, you've seen it already for a better understanding. And you see the flow from the positive part after the pump through the cartridge in the right direction from bottom to top, as Phil said already, back to the negative port pre-pump. If you follow accurately the steps and give attention to the whole system, understanding the flow direction, you will be in short time confident with the system. A few mention to it. CytoSorb is not in the main circuit, but in a bypass circuit. The recommended flow was already mentioned, 400 to 600 mils per minute. The pump flow might vary after opening the CytoSorb circuit. That's why you should adjust the flow. And the direction of CytoSorb blood flow, again, is bottom to top. That's very important. You might need to change the cartridge. Then just think logically about each step you have to do. Clamp and disconnect post-pump and flush the blood back into the pump. But also a very important mention, if there are any clots in the circuit, do not flush the blood back. Now you can prime the new cartridge starting with a step 4. Connect it again as we have seen before, and you can run the flow again through the cartridge. Just reminding a few things. To avoid air embolism, CytoSorb should never be installed in the main Ecmo flow. Never bypass the oxygenator. Otherwise, you will have a venous blood shunt through the cartridge towards the arterial line, impairing the oxygen supplied for the patients. Always pay attention to the flow direction and always in vertical position. Systemic heparin anticoagulation only. Never get air into the device. Recommended blood flow. And if you have ultrasound flow monitoring, you can use it in this circuit. There is also a flow chart you can use and have it near to you to follow the steps for every sentence. Now, we have also a case report in our hospital. We had actually this year from April to June 4 patients with COVID-19 on the ICU who needed a Ecmo, but only one received a CytoSorb. That was a 64 years old woman, about 230 pounds. She was admitted with a dry cough in a hospital. The symptoms were indicating COVID-19 infection, which was confirmed on day 3. Her situation was unstable, unremitting fever. Her CRP continued to rise, so she was transferred on the ICU. Due to vasoplegia, she got a compensatory tachycardia. Under oxygen therapy was slightly better, but not for long. And on day 8, because of her low oxygen saturation, she needed to be intubated and mechanically ventilated. Even that was not enough. Her poor oxygenation, limited ventilation possibility, vasoplegia, fever, that was difficult to manage, and the decompensating trend, the decision has been taken to implant a BV Ecmo. According to the team consent, we started the Ecmo CytoSorb and CRRT at 4 p.m., almost 5 p.m. On day 10. The anticoagulation was kept with heparin, ACT level about 200, 220 seconds rather than 180. After 2 hours already, we noticed a hemodynamic stabilization norepinephrine was reduced down to 100 microgram per hour. An improvement in oxygenation and the possibility to slow down the aggressive mechanical ventilation after the first 12 hours of use. The first CytoSorb cartridge was changed, and the second one ran other 24 hours, and then was terminated. And she remained on continuous renal replacement therapy another 2 days. The Ecmo therapy was ceased after 7 days due to the regaining of her pulmonary function. A day later, she was extubated after 10 days of mechanical ventilation. It followed 3 negative tests for COVID-19, and she was discharged after 23 days of hospitalization. Last week, she came well into the hospital just for a checkup. There you can see the inflammatory parameters from the day 1 when the Ecmo started. As we have heard from Phil, in other studies, it's quite the same pattern. At the end of the CytoSorb therapy, these markers were considerably reduced, and on the day she was weaned from the Ecmo, it is a positive trend noticed towards her recovery. A few words to the conclusion. CytoSorb therapy was associated in nearly all cases with hemodynamic stabilization, vasopressor reduction, improvement of oxygenation, and reduction of cytokine levels. Comparison between earlier or later start of CytoSorb in regard to onset of pneumonia point towards better outcome with earlier start of the treatment, and also in the COVID-19 treatment where no device-related adverse events reported. So thank you very much for listening, and I'm ready for your questions. I hope you enjoyed it.
Thank you both so much. We are now open for questions. Luke, do you want to choose one and begin?
Oh, okay, that's fine.
Stefan, if you could stop sharing your screen and then.
Yeah, that's what I am just now.
So, thank you.
Most questions were around the use of heparin with the device on Ecmo, but as I saw, there is no adaptation to the heparin dosage. Maybe a little more. But are there any other substances or drugs that are removed from the blood, like maybe antithrombin or other drugs that we use in ECMO?
Well, CytoSorb has been used quite extensively in cardiopulmonary bypass, and in fact, they've studied the removal of coagulation factors, and it does not remove coagulation factors to any significant degree. Now, in terms of drugs, because it's a hydrophobic polymer, it has the ability to remove other hydrophobic or lipophilic drugs. And so the main classes of drugs we kind of talked about already, the remdesivir and dexamethasone. And again, the way to treat that is to give the drugs between changes of CytoSorb. The other class of drugs is antibiotics, and we do remove some antibiotics, like vancomycin is a peptide antibiotic, which can remove very well, but can be monitored through therapeutic drug monitoring. But again, we would just recommend that you, if you decide to use CytoSorb, that just have your pharmacy contact us, and we actually have a very good pharmacokinetic data from extensive pig studies where we can offer guidance on how to adjust the dosages of these types of drugs. And then in terms of vasopressors, again, compatible with the catecholamines, and just caution when using monotherapy for vasopressin and angiotensin II, also called Giapreza, which many centers may be using now. And in those cases, just transfer them over to catecholamines, and then to try to avoid this problem. In vasopressors, the rapid stabilization of hemodynamics with CytoSorb that you saw some data on today, for example, should hopefully help them get off all vasopressors at some point. But at the initial start of therapy, that's just something to be cautious of.
Dr. Chan, something that you said I found very interesting regarding the use of the CytoSorb filter in improving renal function. That would suggest inflammation is causing acute kidney injury. So would you recommend the CytoSorb filter for routine cardiopulmonary bypass across the board?
Well, CytoSorb only is authorized under emergency use authorization for COVID-19 patients who are critically ill with imminent or confirmed respiratory failure. So we cannot make any recommendations on other applications, as in the United States that would be considered off-label use. But the logic behind the improvement in renal failure in COVID-19 patients, for example, is again, one, that the hypercoagulability often leads to clot formation, not just in the lungs, but in the kidneys as well. And even though acute kidney injury and renal failure often is multifactorial, there's a lot of factors that go to play in it, such as shock. Prolonged shock can lead to ischemia in the kidneys, resulting in tubular injury and then renal failure, for example. So if we can reverse shock, that may have benefit. But then another not well appreciated mechanism of renal failure is capillary leak syndrome in the kidneys. The kidneys are in a capsule that does not expand. And what happens is that if you start having capillary leak in the kidneys, they will swell to a certain point, but then will not be able to swell any further. And then what happens is that intrarenal pressure rises, and that decreases renal blood flow for one, but also shuts off urine output for another. And the use of CytoSorb by trying to control cytokine storm, reduce this capillary leak syndrome, and help the kidneys try to heal is one of the mechanisms of potential mechanisms of benefit in these patients. And we've seen patients have a restart of urine output and kidney function in this COVID-19 pandemic.
I have some more practical questions. Maybe Stefan can answer these. How do you measure the flow going over the device itself? Do you put in a flow measurement device, or do you calculate it somehow? And is there any in CS, I suppose it's CytoSorb or cardiac surgery, I don't know. How much is the pressure drop over the device? Can you give any comments on that?
About the pressure drop, I don't remember how much it was, but depends on the flow on the Ecmo. We had two measurements we made. One was in vitro and one was at the patient. So you have always a measurement of the blood flow to the patient. This is clipped on the blood line on the tubing set. And when you're making the clips off, so you get the flow to the filter, to the cartridge. We had a little bit of drop of flow measured on the venous line. We just switched the clips, and then you can have a little bit of a comparison between the blood, what you're getting into the patients with opened circuit of CytoSorb circuit and with the closed circuit. And that's the difference to make between the flows. And the other one, it's with the ultrasound measurement. That's what we made in vitro.
I can answer on the pressure drop roughly. If you're running at 700 mLs a minute, it's about 140 millimeters mercury pressure drop. So it's really a low resistance, high flow device. So at that kind of flow rate, that's a pretty good pressure drop.
You know, another comment is that we've actually modeled this, and if you're using an Ecmo pump that is based on a centrifugal mechanism, not a peristaltic mechanism, but a centrifugal mechanism, that because of the different gauge of the main line versus the side port that leads to the CytoSorb cartridge, there's a natural resistance to that. And what we've modeled is that it does not go over the maximum flow rate of the device of 700 mils a minute. So we recommend, wherever possible, measuring the flow in that circuit. But if you can't, we've modeled it that it does not exceed the maximum rating of the device.
Another question from the group is has a patient that you know of or have any experience with that had been started on heparin already running, then ends up with a positive hit panel? Do you discontinue the CytoSorb, or has it been used in any hit patients to your knowledge?
Yeah, so this has occurred, and in that particular scenario, yes, because the device is only compatible with heparin. If you need to stop heparin and, for example, change over to bivalirudin, that is not compatible with CytoSorb, and we recommend, and you need to stop the therapy at that point. And so, yeah. One comment I wanted to also mention is that, you know, I think in a prior webinar at AMSEC that there was a question about clotting. Now, there's nothing particularly special about CytoSorb that would make it clot versus another component of the circuit like the oxygenator. And so the only times when we really see the device clot is typically in the first or second treatment at a hospital, where they actually get air into the device. And that air acts as a blood-air interface that is prone to clotting. And by the way, when that air goes into the porous cartridge, it never comes out. And so that's really the only time that we see that, that clotting occur. And typically at that point, it's because of that entry of air. If you can prevent the air from going in, we've rarely seen that, except for when there's an inadequate systemic anticoagulation, then the whole circuit clots off, not specifically our device.
Okay. Someone asks if it's available in Canada already?
Not yet, but we are working to get it in Canada.
Okay. I've also a question. What is the rationale for having to change the device? Sometimes, so in the beginning you have to change it out after 12 hours and then after every 24 hours, but you can keep it on for 2 days. Why do you actually need to change the device?
Yeah, it has to do with the kinetics of things moving into the beads of the cartridge. And that what we see is that, you know, as you would imagine, things are moving from the outside into the core of the bead, and that takes time. And what we've learned in non-COVID patients is that the accumulation of things in the crust of the bead represents a barrier to additional removal, because those things are making their way to the internal structure of the bead. So we can get rid of that entire rate limiting factor by moving to a brand new cartridge that does not have this issue, if that makes sense. And so, so particularly for patients who are very hemodynamically unstable and patients who are very sick, that's one of the reasons why we recommend this change every 12 hours for the first day, and then changing it out every 24 hours after that.
Okay. Someone asks if you can use it, well, it's nothing to do with COVID-19, but if you can use it for endocarditis, and if there's a beneficial use in Ecmo for ILI.
Yeah, so again, in the United States, that is considered off-label and not allowed. However, in the European Union, there is actually a randomized controlled trial that has been completed called the REMOVE trial, happening at 15 centers in Germany, that was funded by the German government in endocarditis patients undergoing valve replacement surgery. I think for the same reason, these patients are septic with high levels of inflammatory mediators. and also a lot of instability during the surgery and after surgery, often requiring mechanical respiratory support. And so those results will hopefully be announced. The top line results are expected very soon. The trial completed in January. But again, in the United States, this is not an allowed application, and we are only authorized for treatment of critically ill COVID-19 patients with respiratory failure.
Has it been used in children?
Yes, but not COVID-19 patients. In the United States, COVID, again, we are limited to adult COVID-19 patients older than 18 years of age. But in non-COVID cases, it's actually been used most recently in an emergency use case here in the United States on a patient down as small as 2.5 kilos. So very small. And there have been actually many cases published. And if you search pediatric and CytoSorb under PubMed, you'll bring up many of those cases, but not something that we can really talk extensively about here because it is considered off-label and not allowed in the United States.
Thank you.
Sure.
Do we still have time for questions?
Yes, I think we can do one more question, I think.
Okay. Yeah, there's two more. Someone asked, why is CytoSorb contraindicated in patients with high BMI? I don't know if that is actually the case.
Well, the simple answer is that for those with a BMI greater than 40, it's almost like treating two patients with treatment meant for one. And obviously, patients who are morbidly obese also have very bad lung dynamics. Some of the patients, in fact, that you saw presented today were actually quite large with a very high BMI, so it can be successful. But generally speaking, it's really inadequate treatment for a person of that size. Even though the blood volume doesn't quite scale, that way, but it is a lot of inflammation to cover with a single cartridge, and that's one of the reasons why it's contraindicated.
Would you advise putting in two cartridges?
So we have tried that strategy. We've never done it early in these patients, but what they do is that they've treated more frequently. So as we're recommending every 12 hours treatment, it's actually been used every 8 hours of treatment, for example. So to get a higher dose, as we were talking about. But it's not something that we have a lot of experience with.
Okay, thank you.
Sure.
Stefan, one last question. It was, you mentioned the increase in blood and air interface, and one of the participants said they'd heard that there was difficulties in de-airing the cartridge while in the priming sequence. Are there any tricks that you can share to prevent this?
First of all, you get a filled cartridge already. And it's very important that the priming line, the purge line, to be filled previously. Because if it's full of air and this air is getting into the cartridge, that's very difficult to get it out of it. And if you really follow the steps and really avoid getting air into the system, this is very, very important. It's not going, I've never seen a cartridge after it being de-aerated properly that is coming other bubbles up to the top of it. So if you flush it properly and get all the lines filled and connected bubble-free.
That makes sense.
Yeah, Stefan, as you correctly point out, it's shipped in saline, de-aerated to begin with. Sometimes you may see a small bubble at the top, but that during the flushing procedure, that comes out. And so any comments on that, Parker or Vince?
Do you have a formal protocol for use of the CytoSorb filter?
Yes, for COVID-19 patients. We have an IFU. Yeah, we have an IFU that's available. If you go to www.cytosorb.com, And we actually have a whole section on COVID-19, and under there are actually all the documentations needed, including the IFU on how to set this up. There's a lot of other helpful information there as well.
So Linda, it's actually shipped with the IFU that's approved by the FDA. You
Okay.
can actually find it on the FDA website as well, all the documentation associated
Perfect.
with this.
Perfect. So with that, I want to thank you again for joining us today for this webinar, and thank you so much to our speakers. The recording of this webinar will be posted on the Joint Perfusion Task Force website within 2 days. At the conclusion of this call, all attendees that have joined us on their devices will be provided with a link to complete a survey to claim credits and provide us with feedback on the status of your program's operations. The link to the survey will also be automatically emailed to all participants 1 day after the conclusion of this webinar. And we would greatly appreciate your participation in the survey to help us guide our future work. Thank you again to CytoSorb Corporation for their sponsorship of today's webinar. And if your question was not answered, please join the discussion on the Joint Perfusion Task Force website and post your question to this discussion forum. Again, thank you all and take care. Bye now.
Thank you.
Thank you.